Start.
Good morning, everyone. It is Monday, February 3rd, and we have the distinct pleasure and honor of having one of our own, Emeritus Professor Dr. John Brock-Utne, very well known to us as a mentor, friend, someone to bounce ideas off of, advocate in regional, national, international spaces, part of the CSA leadership for a long time. So without further ado, I introduce this topic: have we lost control of our workspace? Take it away, John.
Okay, you can all hear me, I hope. Anyway, good morning. So there was some confusion about the title, but here we have that's the physicians or healthcare care providers, lost control of our workspace. By workspace, I mean the environment in which we work. And some of you may have read this book by Amor Towles. And of course, this is a story of a gentleman account that was put into jail, but not in the jail. He was put in a hotel in Moscow for a duration of many, many years. So he says a man must master his circumstances, otherwise be mastered by them. And we'll get back to this in a minute. We have, as you know, plenty of administrators. They get more and more of them every year. So I want to look at how many people are employed in a typical California hospital. So let's take a hospital of about 800 beds. There are something like 12,000 employees. 35% are involved with direct patient care. That's doctors, nurses, etc. 65% are not involved with direct patient care. 20% are support staff. That's medical assistants, equipment, laboratory. The rest, 45%, are not involved in any direct patient care. And they are finance, documentation, IT employees, guest relations, etc. So they, hospital administration, justify their existence by supposedly improving efficiency and quality of care. But the value of the hospital administration, and especially CEOs, has become under increasing scrutiny. And you can see the Boston Globe here. So in this book by Elizabeth Rosenthal, the physicians, as you know, took an oath to improve quality of life and save lives. And in this book, she says that the excessive number of hospital administrators at the helm of our healthcare system are not committed to the same ideal. It is a fact, she says, that the American health system has stopped focusing on health and even science. Instead, it is concerned only with profit. So we'll discuss how many hospital administrators do we need, and we'll discuss many of these other topics, which I come into in a minute. But let's go on to how many hospital administrators do we need. Actually, there are no studies. I certainly couldn't find them. But there are many studies on how many healthcare professionals are needed. That's totally different. And so if we go to compare two hospitals in California, one has 45% employees doing direct patient care, while the other had 78%. So how can one hospital get away with only 22% administrators? Well, the fact of the matter is there is no state or federal government standards. Every hospital do their own thing. There are no checks or balances. So whatever a CEO or CFO needs, they will hire. So which of these two hospitals have better outcomes? So you've got to perform outcome studies from several institutions across the country, a massive scope of work, and you have to get the NIH involved. Other option is to compare a comparative analysis with other industries, like for instance, technology, and look and see how many people are working in IT, in finance, risk management, and trying to get a comparison. Again, a massive scope of work that, in my opinion, something like that needs to be done. So as you can see, since 2005, there's been a tremendous increase in healthcare workers, a 5% increase in doctors, nurses 35%, and hospital management 60%. There's also an increase in salaries. MDs have gone up 18%, nurses 27%, hospital administrators has gone up 55%. This is the work I do in clinical orthopedic related research. I want to focus on number 5 column on the from left to right. And you can see here is the increase in a wage gap between, for instance, CEO and a registered nurse. And you can see it just gets more and more. So is this something that fact that administrators are making a considerable amount of money, is this known? I would say it is, because this comes from a Sunday cartoon by Rob Armstrong. And if you can see, this lady has got the opportunity to run a hospital, and the child is extremely happy. We are rich. There is a definitely bureaucratic road, and this lady, Ofri, in the New York Times in 19, has shown a 3,200% increase in healthcare administrators since 2005. And that's all paid by the patients and their insurance. So have you got any later? Have I got any more recent references? Well, here's a Daily Mail Health, November 27, 2024. They have discovered that 570 billion US dollars in annual healthcare spending is wasteful. That is about 10 to 15% of total healthcare expenses. So the 570 billion is squandered annually on administrative costs. And that means that there's also another thing that happens too, is that we're also involved in carrying on the administrative burden. We spend at least 10 or 20% of our time of unrelated tasks, which basically related to billing. And so the bureaucracy is destroying more and more value in the healthcare. And this is an important paper come out of Johns Hopkins School, that they found that hospital administrative expenses grew faster than clinical expenses. I'm sure that's not what we want. Hence, larger share of the hospital financial resources goes to pay hospital administrators. And this leads to less money for patients, drugs, and equipment. There is also no correlation between the CEO pay, hospital quality, financial performance, or even community benefit. So the solution to all this is to decrease hospital costs by reducing the number of non-revenue generated healthcare workers. And here is a suggestion that Medicare and other insurances should link hospitals and medical schools reimbursements to a verifiable ratio of administrators to active healthcare providers or patients. It's got to have a verifiable ratio. Then we can compare apples to apples. So when I qualified in 1968, this is how the hospital administrators were viewed. This is according to The Puritan Gift by Ken and Will Hooper. A lovely book, by the way. There were no display of wealth. I mean, you look into 500p, a beautiful building, you would never see that in 68. There's a trace of Puritanism at that time, humility, frugality. And my first job in Dublin, there was a 250-bed hospital. We had one administrator and 2 secretaries. That was the state of the administration. So in 2019, according to this book again, the administrators are viewed to have, or by those who have no direct patient contact, poor governance, excessive pay, and the lack of deep corporate culture and corporate malaise. So we'll now discuss a bit of value-based purchasing program, VBP. And this was a colossal misstep. The whole idea was that CMS wanted to change the way hospital was being paid, or the reimbursement, and it was going to be based solely on patient feedback. And this value-based purchasing program, that was a total failure, and they tried something else, which is a mouthful, of course, hospital consumer assessment of healthcare providers and system. I'm running out of air. And by also measuring patient satisfaction. This also was a complete failure and a total waste of money and time. However, they went on to create something called Press-Ganey survey. And this was a measure of, again, patient satisfaction. And these Press-Ganey surveys then were sent to the hospital administration and also to the heads of department. And in many parts of many hospitals in this country, the MD salaries are dependent on excellent Ganey Press score. And the score is between 1 and 5. Most MD gets between 4.5, and anything else is actually no good. But most patients, when we are patients ourselves, we gave 4 to 5. I'm sure many of us did give 5. But some never give more than 3 and 5, 3 out of 5. So hence, in that case, you get below 4.5 and you get less pay. So one MD didn't get the average score of 4.5 and her salary was decreased. So she managed to investigate the patient's responses. And she found that a certain population group never gave more than 3. And so the solution for her was to by refusing or minimizing her exposure to this group. And of course, the result was her salary improved dramatically. So this is not what we want. I mean, really. So my suggestion is to get rid of this. It's very expensive. It's unfair and divisive. I mean, a bad experience with a valet parking can influence a patient's score. And also, I think that if you're going to do a hospital survey, we should do 360. Let the physicians and patients also survey the hospital administration and all the workers with no patient contact. Why not? This is democracy. That, I think, will be very interesting. Of course, I won't have time to ask you now, but of course, I'd love to know. I did give one in person the other day, and it was quite interesting how people guessed how many metrics most an average US hospital report every year. And the number actually is over 500. This is obscene, ladies and gentlemen. All metrics are also unfunded and unsubsidized. I'm going to repeat that again. They're all unfunded and unsubsidized. And we need to diet these metrics. And every year, more and more metrics are added. So, solution for this obscene number of mandates is to insist that all hospital mandates and regulation must be funded by the issuing body and not by the hospital. If the state of California wants us to have this, well, they pay for it. And then it will be interesting to see what the public thinks about that. So now, in our situation now, the hospital pays. That means that the patients pay. That means that you pay. It means the insurance company pays. So we have, for instance, HIPAA. It started in 1996. It's also not funded, not subsidized. And of course, many of you know how HIPAA was created. And for those who don't, I summarize it quickly. In about 1990 in Florida, the mother was a nurse, a scrub nurse in a hospital, came home and put the next day's operating room lit on the kitchen table, and then she rushed out because a neighbor called her. And then her daughter and a friend, around 16, looked at this list. And of course, in those days, many of you have not seen it, but in those days, totally wrong, absolutely rubbish. It had the name, full name, it had date of birth, it had sometimes social security numbers, it had every conceivable thing and a telephone number. So these two young ladies decided that they would ring every patient. It was about 150 people. And they rang every person and they said, this is the hospital here, you have AIDS. Now, because of all that, this whole HIPAA was enacted. Instead of, and in this case, they found out where the phones came from, so they knew exactly who the nurse was. And instead of saying to the nurse, look, don't do that again. If you do, you will lose pay or you will lose your license. We created this monster of something called HIPAA. However, I want to say, HIPAA has been very good because now, if you look at your next day's operating list, it's got just the essentials that you need for providing your service. Here's a novel idea. Get rid of it. A patient will save money on expenses, HIPAA expenses like hospital software development. There's something called Iron Mountain, 9 billion market cap. You see these big trucks traveling around. They are shredding papers and document management. Hospital personnel that oversees the mandate, that is done properly. Also personnel training to navigate the HIPAA compliance. And here again, I would suggest that all hospital mandates should be put to the vote by the state voting public. Let them vote. Let's have a ballot. Hospital committees, I know that many of you belong to hospital committees, very important committees. And if I was physical, I'd be able to ask how many of you are members. But what percentage of these meetings do you think a doctor can attend every year? Well, I surveyed in 2021 and found that 70 to 90% of working anesthesiologists cannot attend meetings regularly. They are busy generating income for the enterprise, for the hospital. Now, these committees are called, as advertised, physician-led healthcare. That's a total misnomer. When only 70 to 90% of the working physicians can attend the meeting regularly. So if you can't attend as a physician, you cannot contribute. Hence, these protocols are made by administrations. Most recommendation protocols are not based on scientific facts. You look at some of these protocols. And this leads to expense for the patient, burden for the patient, time wasting for the physician, and health costs increasing without any evidence of improved healthcare delivery. Here's an example of hospital administration misadventures, and I know many of you know this story, but I'm going to tell it to the people who don't know it. So this is the IV spiking mandate of 2016. The USP told the Joint Commission, that JC, and the hospital administration that all commercially IV bag must be spiked either in ISO class 5 clean room or be used within 1 hour of spiking. So if it was 60 minutes, you had to throw the bag away. The object of all this was to prevent microbial contamination. And this is an example of what an ISO class 5 clean room. So every IV bag had to be spiked in this room. And you know, you've seen these rooms probably. They're an anti-room, everybody dressed up like this, etc. So we said to ourselves, this is the maddest thing we've ever heard in our lives. This has been going on for over 100 years. We've been spiking it all over the place, in the wards, everywhere. And we then looked at the USP, Dr. Jaffe and myself, and we discovered they misinterpreted. They misinterpreted their own laws or rules. And 797 has nothing to do with spiking. So we did our own study and showed that IV spiking does not cause microbial contamination even after 9 days. And we convinced the hospital to return to 24 hours. This spiking, ladies and gentlemen, was done in a busy workroom in 300 people. So we saved, in those days, we convinced the hospital to return into 24 hours, and we saved the hospital for at least 5 million for not building an ISO 5 clean room. Now, you can imagine a big hospital like Stanford they will probably need 2 or 3 of them. And now that's 15 million. Now, everyone in Stanford was very happy that we got rid of this spiking fiasco, because a lot of the technicians got tendinitis, and they were off work. I mean, they were spiking and spiking and spiking every hour. I mean, the whole thing was ridiculous. Anyway, in 2022, the spiking demon rose again. And Dr. Jaffe, who unfortunately, as some all of you know, is no longer with us, which is tragic. But this gentleman, a very clever fellow, he actually took upon himself and he wrote to the USB. And he managed to get it up to the high level or echelon of USB through some people. And that's a trick. You've got to get to the right person. But anyway, this is what he wrote. And I want you to read it carefully to yourself. I'm going to read it to you because this is very, very good. So he wrote and said, does the USB have any evidence that IV bag spiked for more than 1 hour is unsafe? If so, then USB must disclose this evidence. Failing to do so will raise a serious medical legal liability for USB. Well, ladies and gentlemen, within 3 weeks, that whole spiking demon had gone. They renated on what they said, and the spiking demon disappeared. I want to quote you now from Jeremy Hutchison, Queen Elizabeth II's lawyer, who also I consider a clever man, just like Jaffe. And he said, the ability to stand up to authority is second only to good health as the most important thing in life. Remember that. Now, the importance of overturning this false mandate should not be underestimated. And why? Because every hospital, as I said, will have to have at least one. And they're costing 5 million each at least. And there's 6,120 hospitals in this country at least. You can do the maths. So Dr. Jaffe actually managed to save the US health budget about $30 billion. Here's another example. It took us 9 months to move needles and syringes on an anesthetic cart. We got a new anesthetic cart, and you have seen them. We still have them. And initially, the needles and the syringes were in the bottom drawer. And we were bending and bending and bending, okay? And Dr. Quick, Alex Quick, a wonderful chief resident, lovely fellow. He works down in San Diego now, lovely man. And he took it upon himself to say, this is nonsense. And these are the type of people we want. So he does made 54 phone calls. We got involved with this, and we had presentation. We met with a lot of people. 9 months later, success. We managed to move the syringes and the needles to the top. Very good. And here's the reference. But you've got to remember that if you get involved with a QI project, and we learned this very quickly, there are challenges. There are competing regulations. That's number one. 2, there's a hospital administration over-processing. They must show a right to exist. And that's why it took 9 months, because every committee had to say something. And the third thing is lack of dedicated QI funding. So when you are actually going to do some QI changes, there's no funding for it. So I just wanted to remind you of the 4 basic principles that administrations will do use when you're handling your concerns. First of all, they express appreciation to you for sharing your concerns. They indicate full understanding of the importance of problems. Of course, they really do not. And your concern will be investigated, and a full report will be given in due course. And the beauty of this approach is that you can't object to anything they said. They have not promised it to be ready. They have no remedy. No time frame has been established. And it quietens you. You walk out and you feel quite good. And they have bought time for the problem to self-correct or go away. Or you go away. Let's talk about the root cause of drug shortage. So the old supply chain was many suppliers of drugs or equipment on one side, providing their supplies to many distributors, and then went on to many hospitals. So in 1910, something called Group Purchasing Organization, GPOs, were formed. GPOs initially didn't have anything pay to play, but they eventually they come on to the fact that let's make the suppliers pay to play. Clever, clever, clever. And it went on for many, many years. And that meant that if you didn't pay the GPOs, you couldn't participate. You couldn't sell your drugs. So many of these companies went under. So in 1972, Nixon got rid of it. But in 87, Reagan got it back in again. And he granted an anti-kickback exempt. And any kickback, we are paying. The patients are paying, the insurance company paying. We are paying for this. So these are the situation that we have at the moment at the bottom. Few suppliers, GPOs, and then we have GPOs that goes to go to the hospitals. And this is mentioned, of course, in Marty Mackay's, who is going to get I presume, can get a big job in a new administration. This is a good book, by the way. So the things you should know about the drug shortage. There is a strong association between critical drug shortage and decline in drug supplies, as I explained to you. Now, GPOs makes it difficult, impossible for non-GPOs manufacturers to enter the market because they don't pay, they don't play. Our independent studies have shown the hospitals can find better deals outside GPOs. Ooh-wee. And the GPO kickback has been worked out to cost the healthcare annually $37.5 billion. There's also a generation of false news. I happened to be in Puerto Rico after a large hurricane struck Puerto Rico, and we were inspecting hospitals. And I said to them, I'm very sorry about your factory that's making IV that has been flattened by the hurricane. They said, what? I said, it's been flattened by the hurricane. That's what we've been told. Absolute rubbish. Nothing wrong with it. Fake news. Remember, some of you will remember, we had no IV because of the Puerto Rico plant had been decimated. According to my pals, this was not true. This is the Federal Trade Commission Chair, Lina Khan, doing a good job. She will be replaced by somebody else, and maybe Mackay, I don't know. But she has stated that GPOs, by most unconflicted, and I love the word unconflicted, is the cause of this drug shortage fiasco. Be aware that the GPOs will fight like hell to protect their safe harbor. So it's not going to be easy to get rid of them. And I just want to tell you that I started fighting them. And if you look at Brock-Utne, search it on the web, you'll see a lawyer called Scott Peterson, who brought me up to the ethics committee at Stanford University. I got cleared, thank you very much. Oh yeah, these people play hard. They don't mess about. So be prepared. Here's another takeout on burnout. So there are wellness experts that blame burnout on healthcare providers for their personal failure. They maintain it can be remedied by, for example, coaching. And this is the article. So this is written by a famous man called Schoenfeld. And his title was Effective Professional Coaching, Intervention on Well-Being and Distress of Physicians. And in the study, they recommended coaching. However, if you were to read the paper, and you should always read these papers, and the results showed after many, many months of coaching, there was no improvement in the 4 typical burnout measures: job satisfaction, engagement, depersonalization, and meaning of work. No improvement whatsoever, but still they're recommending it. So one wonders if the coaching didn't work, but when was the coaching done? Was it in early mornings, evening? By whom? Psychologists. How were they trained? Who paid them? The hospital? Or did the physician pay? And what about the loss of income to the hospital and to the physician, for that matter? So we wrote a letter to JAMA, and we said, quite rightly, which is true, burnout is multifactorial. But the cure is simple, very simple. Reduce the bureaucratic impediment to patient care by reducing the bureaucracy. Reducing the bureaucratic impediment to patient care by reducing the bureaucracy. Establishing a true working physician-based healthcare governance. And then put the hospital management in the hands of practicing healthcare physicians. So we believe that physician burnout is largely due to policies of the institution. It is not a lack of physician stress management. Come on. We have had stress in our life. We have spent 13, maybe 15 years getting to where we are. We have had a lot of stress. We know how to deal with this. And then we also managed, most of us, to have and maintain a proper life balance. Now, we are told to increase our clinical and clerical responsibilities too, but have little control over the environment in which those responsibilities must be fulfilled. Which brings us back to Count Rostov, doesn't it? A man must master his circumstances, otherwise be mastered by them. Be mastered by them. So here's some suggested solutions. We're coming to the end line, ladies and gentlemen. We are going to get rid of the GPOs. We have to. This is going to save us something like $37 billion a year. We're going to get back to the old system of competition, capitalism, whatever. We also have to reduce the non-revenue generating healthcare workers. We got to get onto a verifiable ratio of administrators to either doctors or patients. We got to work this out, ladies and gentlemen. We're going to get rid of all the excessive mandates. All these mandates should be put to the vote by the state legislators, voting public, I mean. They should put on the ballot. And if people see how much this costs, they will vote to get rid of it. And as I said about HIPAA, software development, the Iron Mountain, personnel payment for these people to oversee the mandates of training, and also a decreasing of executive salaries. CEO of big hospitals in this country are sort of earning $7.5 million a year. That includes bonus. That's an awful lot of money, ladies and gentlemen. So now the cost savings that we could get could employ practicing physicians to be part of the administration of the hospital, thereby changing the system from within. You all know Mao Zedong and how he took over from 1917 all the way up to 1949. And he's still there. Not him, but the party. And paid practicing MDs for being part of hospital committees like the pharmacy, thereby giving physicians oversight of healthcare to the benefit of patients and also themselves. Insist on a government investigation to find out how many hospital administrators are needed for a given hospital, depending on numbers of MD, nurses, or patients, whatever they're going to decide. But we got to have some verifiable ratio. And the hospital board should actually demand a detailed justification for each VP, each deputy dean, all employees with no patient interaction, and get rid of the GAN pricing. This is, let the physician also survey hospital administrators. I think this would be very interesting. Burnout, restore the control of healthcare to the practicing physicians, and nurses and the patient they represent. And solution, this is actually very important. Support your CMA or CSA. I know that you are now members, thanks to the department of the CSA. But when you leave, you really should become member of these organizations. Did you know that 1,800 bills are produced annually by the California legislature? And the CMA especially reviews all these bills and trolls them for seeing anything to do with healthcare. Now, for instance, they managed to succeed in Prop 35, securing $8 billion to provide permanent funding for medical health care services. That's a big thing. And so many of these people are like president of the CMA. He's one of the top, most powerful people in Sacramento. Well, CMA, of course, got 44,000 people as members, so it carries a bit of weight. But these are important things to get involved with and support. And of course, join or form a union. These are important. I don't like unions personally. I remember I'm Norwegian, and I started working. I was going to be hospitality for work in hotels and be an hotel manager. That's what I was going to be anyway. And so my first job, I got my salary slip, and there was this 10% taken off or 12% taken off. I said, "What's that?" Well, that's a union. I don't want to belong to a union. Well, if you don't belong to a union, you've got no job. So there is that part of it. If you're going to join a union, you're going to try and find a good one. And the way I recommend it is that we try and change the AMA. In other countries in the world, the British, the French, the German, the Norwegian medical associations are the unions also, providing education support, etc., but they're also union. And you have no idea how strong it is when a union comes and stands on your shoulder and negotiates. And we have written, of course, about this, and we have one of our own, Bogart, had written about this. And I think there are opportunities. I think I'm not necessarily agreeing with there are challenges, but I believe we got to find the right one. And the AMA would be the one I would go for. So I want to end with 3 quotes. This is Thomas Sowell, Hoover Institute, Stanford. It's hard to imagine a more stupid or more dangerous way of making decisions than by putting those decisions in the hands of people who pay no price for being wrong. Who pay no price for being wrong. And the second one is Margaret Mead. I love this one. Never doubt that a small group of thoughtful, commitment citizens can change the world. It is actually the only thing that ever has. And lastly, from Helen Zille, a South African anti-apartheid fighter. There are always things you shouldn't say. But then you have to think of the price you and others will pay for not saying them. And on that, I wish you a good day and keep your patience pink. Thank you.
Thank you for that talk, John. We have a couple of questions, and then if other people want to add questions for the speaker, please go ahead and do so in a Q&A function. So the first part, Dr. Ramamurthy talks about encouraging people, meaning healthcare providers, to be on committees and get non-clinical time. And this is what we're calling citizenship or physician leadership. So I guess that means that we're also does that also mean then that we are part of the problem?
I believe that I think these are physicians that are also working. So I say it's working physicians. And I think as a physician, you'll always be a physician. And I think when you join the committee as a working physician, you will have the patient first and foremost in your sight and making sure that we're doing the right thing for them.
So I kind of want to, before I go to the second question, I want to ask you this. Is it that, I mean, there's a lot of non-clinical work that has added up in a physician's life, right? It's no longer a patient comes to us with cash in a bag, we render services, we get paid, and then we go away. There's the whole insurance billing thing, which is more complicated and beyond the remit, I would say, of an average, busy, full-time physician. Would you first, what are your thoughts about that?
Well, Epic was created. We got Epic, and it was basically created for a billing. It was a billing platform, basically. And I don't know how we can, as physicians, refuse to do that, because it's also part of we're filling in the form, we're filling in all that. I have difficulty answering that question, because we got to pay, we are providing service, we're providing information, but a lot of the information we're providing is actually for billing, as I just said. And we can't just refuse not to do that. We just got to do what we can, because it's part and parcel of providing healthcare, or making sure that we're doing the right thing. I'm not answering this question very well. But I find it difficult to. We can't just step away and say we are not doing this. We can't do that. That's
No, that was part one of my question. So the
yeah,
part two of that question is that if we are unwilling to sort of, I mean, obviously we're willing to do the epic part of it, but the whole billing of insurance companies and stuff, which is a whole other thing, we need somebody else to do that work, right?
absolutely,
So,
absolutely.
so that's where the administrators are coming in. And then now we create the problem of saying, oh, but these are all people who are not contributing to patient care, but in fact they are. And then finally, it's like, I mean, I think the way forward is that we need a seat as healthcare providers, we need a seat at all the tables, right? If
Oh,
we just
absolutely.
say that we're just going to care for patients and nobody else, then that becomes a little bit of a difficult problem, because
Mm.
then we're giving up control of. So I agree with Dr. Ramamurthy when she says, like, we're all encouraged and we should be part of administrative role. We should have administrative roles, because that's the only way we can A, see how the sausage is made, and B, we can divest the dollars towards patient care more, so I don't know if we need less administrators. We just need I would make the argument that we need to be more involved in that space as healthcare providers. So that's, instead of getting rid of them, we need to populate
Yeah,
those spaces.
I think that uh, I don't know what it is now, but it certainly was when I was working. Every insurance company had their own forms. And I don't know if there still is now. And I've always been shouting, we got to have one form. Every insurance company must have one form. And I can tell you a story that many years ago now, we're going back into the late 90s. Or maybe early 2002 or 2003, we did a patient. I won't give much information about it, but it was a patient that came in. And this person was a president of an insurance company. And first of all, he wanted only me to look after the patient, which was dangerous in itself. But anyway, so he didn't want a resident, and he only wanted the attending surgeon. And then I had to explain to him, this is a university hospital. This is what we do. And if you don't want it, and then I looked and saw that he was a president of the insurance company. I said, well, this is what all your patients get. I'm terribly sorry, sir, but you have to get the same as everybody else that you are providing a service for. Anyway, he was a very difficult person to deal with. Ooh. And eventually he left. And many months later, I spoke to the surgeon. I said, you remember our patient, you stand and talk. And he said, Yeah, oh, do I remember. I wonder, did he ever pay? I said. It turned out because the forms had not been filled in properly, etc., and the time of 6 months had gone, he never paid a penny. Now there is a problem. I mean, so what I'm trying to say is that if we could simplify the forms that the insurance companies are using, then we can get rid of a lot of people. It will make so much life so much easier for us. And I'm not quite sure if that has been done now or not. That I have no idea. I haven't looked into it. I should. Maybe one of you would like to look into it. But that's so. Yeah, I see what you're saying, but I still think we have too many administrators.
Moving on to the next question, also from Dr. Ramamurthy. Can we look at how many, or maybe you have the answer to this already, how many MDs were added to the department and how many administrators were added over the same period?
I haven't got that for this hospital. I haven't, but I can, as you saw from the study of Doe, there was a tremendous 65% compared to. I mean, you saw the graph. The doctors are just, the physicians and nurses are staying more or less steady, while they're just going up and up. I haven't got any answers for this department or this hospital. No.
Okay. Next question. Undoubtedly, the bureaucratic and regulatory demands on hospitals is increasing and remains an unfunded mandate. In regards on how the federal government has tried to manage rising costs, such as value-based programs and incentive programs, such as merit-based incentive payment system. Any comments on the success of these programs? First, and then second, are they working on reducing costs?
You know, you know, you try and look into this. That's a very good question, by the way. I don't want to waste time on it. I think there's different people say it works beautifully. And some people, when you read somewhere else, they say this is the disaster. I mean, it is just so complicated and it's so unfortunate and it's so much false news. And I get very depressed about it. I think we need somebody to get in there objectively to look at is this working or is it not working? That's the question. And I totally agree with you on the question. I think we got to find that out. And I think at the moment it's up in the air.
Well, part of the problem is how do you, I mean, if we as an academic institution, our mandate or our ask is that we do cases that nobody else wants to do, right? Meaning we have a responsibility to the patient population to offer high risk things with the idea that we have innovation, talent, et cetera, and training. So obviously those outcomes are going to be different than standardized outcomes. So when we say value-based programs, I mean, what value are we saying? I mean, if the patient makes it out, is that the goal? Is it that they go out better than they came in? Is it that they are alive? That's enough. I mean, like
Exactly.
it's just I don't understand what the benchmark is.
Yeah, that's exactly what I'm worried about. But you know, the studies was done by one of our own, a guy called Bill Forrest, back in the 70s, a long time ago now. And he's still alive, this gentleman, lovely man. And he did a study on hundreds of thousands of patients, comparing small regional, sort of not cottage hospital, but hospitals out in the rural district compared to bigger hospital in university, etc. And he found that the outcome was much better in the bigger hospitals, the university hospitals. So there is data to show that that is certainly happening. That if you have but value-based, I agree with you. What are we looking at? I mean, people throw these words around. We got to get somebody in there we can trust to look at this and say, this is rubbish. This actually is working.
I mean, I wonder if Kaiser has the answer, right? They have
Right. A
they
lot of
probably
people
have.
think they have the answer. I would agree with you. I mean, the Scandinavian model is a lot of Kaiser. But you know, it's I had a cousin of mine who broke his leg. He was being treated with chemo and in the university hospital for cancer of his colon. And he broke his leg. I was with him, and I brought him back to the hospital where he was getting the infusion. And they said, no, we can't take him here, even though they had an orthopedic hospital. No, no, you live in this district, you must go over there. And so he had to go to another district where they had an orthopedic surgery, and he had this done. But he lost out nearly a month of chemo because of it. So sometimes I think it, and I hear stories from Kaiser, and many people are very happy. Some people are not so happy. And I think it is very difficult. I really don't have the answer to all this unless we get the facts. I'm just pointing out that we have a problem and we're wasting money on people, and that we could trim our bureaucracy, and that will be helpful to the bottom line.
Uh, our next question is two questions are from Jordan Newmark. Um, Medicine has become industrialized, meaning faster and efficient, but we have less face time with patients, more tests, etc. How do we stop this culture? That's one. And is it too late to, if this is the root of the problem, is it too late to change it?
I think the only way we're going to change this is from within. I think we have to get into the hospitals. We have to, some of the things I mentioned, for instance, I think that we got to, they got to, I mean, when I tell my colleagues around the world that a CEO gets $7.5 million on average for a big hospital, well, they look at you and you say, that's your problem. We don't get anything like that. Our CEOs maybe get 200 or 300,000. And then we have all. I think we got to get rid of we got to reduce the bureaucracy. As to his question, I think there's always hope. I'm hopeful that if we can get involved and the public also begins to realize that we have lost control, and that we put all these mandates up to a ballot, that people start voting. We can get rid of the HIPAA, for example. HIPAA did a great job. I'm not disputing that. I think it did a great job. But now it's done its job. We can get rid of it. And then if anybody can be shown that they have given personal information to papers or newspapers or whatever, well, they have to pay the price. Either they lose their job or they lose their license, they reduce we got to get to that type of simpler than having all these mandates. And I really think there is definitely hope. We got to be hopeful, but I think we got to actually take control of our destiny and get involved with the hospital administration and change it from within.
I wanted to share because we had talked about merit-based and value-based
Yes.
productivity. Dr. Lorenzo has added a couple of PubMed IDs onto the Q&A. Candace, could I ask you to publish this? Just send this out to the entire department, just so that we can read it later, if that's possible. Coming on to the next question, you mentioned that administrative bloat has exploded. For example, even here at SHC, there are dozens of vice presidents. How does a system even start addressing such bloated bureaucracy? Is it even realistic to expect that this can be streamlined?
Well, if we don't try, we don't judge. I think that the hospital board is the one who can do it. The hospital board if you go to them and speak to them and say, look, can you please I tell the hospital administration what is the value of this vice president, what does he do, and etc. Start asking questions, not just sit there and have a nice lunch, but really get involved with how the hospital is done, how can we save money, what is the value of this person and that person in the administration, and what are they doing? Can we not make this better? Start asking questions. That is what the board should do. The hospital board should get involved here.
This is another question. We are an academic center. The current flow of money and power is from the clinical side to the research side. How do we get the department to value clinical work? For example, on recent bonus forms, only faculty who published could get full points. I wonder if that's directed at someone else, John. You can take a stab at it if you like.
Well, when I started there, going back many years now, there were many more. We had to publish, otherwise we'd be kicked out of it. And now we have these educators, which is wonderful. I think they are there to teach and education, but there's no need from the hospital or from the department point of view that they should publish anything. And there are 90% of them are in the department, are this group of people, which are wonderful people. And so hence, they don't have to publish. They got to provide good clinical care and good teaching, and they get promoted, quite rightly. And so there's a different group of people as compared to when I started, as it is now at the moment. So I can't really compare. It's difficult to compare the two groups. We had to publish. If we didn't publish, we were out of here.
Okay, so that brings us to the last question. We have 3 minutes for this. Committees are a funny thing. I was chair of a community department of 60 clinicians, and I missed 90% of my required meetings due to required patient care and lack of admin time given to me. Comments?
So the question is, this person couldn't attend 90% of these meetings because of working and didn't have admin time, etc. I got it right?
Yeah.
Okay, well, that's exactly what I'm saying. That's exactly what we have found in our survey of anesthesiologists, that people, up to 90% of people, never get to these meetings, and they say it's physician-led. And this is really what I'm grumbling about, is that they make these protocols, and there is no benefit whatsoever on many of these protocols. We need to get paid to do it. If they want to have physician-led committees, the physicians has to be there. Otherwise, it is run by administration-led committees. There's not physicians. This is a misnomer. We got to get back that we are the ones that make the decisions for the patients in their best interest.
And then last but not least, a comment, a sobering comment somewhat. If you're not at the table, you'll be on the menu. Whoever has the gold makes the rules. Unfortunately, even stipended meetings are essentially a pay cut for higher paying specialists and a pay raise for non-specialists. So these committees are filled with well-meaning folks with less and less clinical experience. Nevertheless, we have to keep fighting for pragmatism at these table discussions.
Yeah. Yeah, this is why I gave this talk, because it's more of getting everybody to wake up. and to wake everybody up and say, these are some thoughts. I'm not saying I got a silver bullet. This is not going to be an easy task, but we got to get back and get control of the situation. The answer to that question, I'm just here to get you all. I'm not revved up, but
It's an important question. And
yeah.
with that, before we end, I just want to share another resource that Dr. Oakes has provided. She mentions Jeffrey Pfeffer, a Stanford Business School professor who speaks extensively about how the healthcare system has disempowered physicians, and he promotes the need for physicians to lean into their power to help improve healthcare. He's written a book. It's called Dying for a Paycheck, which discusses many of the challenges of management systems in all industries, including medicine. So it looks like it's an endemic problem, not just in
Yeah,
health.
that's interesting you say that. It's actually quite interesting. I actually had some contacts in the business school, and I said, I can give this talk. You might have some interest. And I got hold of these people who were supposed to be professors and involved in healthcare, etc. I never got one response back. It was like being stonewalled. I'm terribly sorry to say it. And I had some insight and inway into it. And I was never invited. Not that I want to talk to everybody, but I found it remarkable that this hospital, I know this person or know of this person, and that they wouldn't sort of get their students in there and talk about this healthcare crisis we have. We have a healthcare crisis. And we are misspending our money. More money is going to administration than going to the patient. Often do we see we got to save, we can't use this drug and we can't use that drug, or we got to watch out for this and that because the hospital is running out of money. I mean, I'm sorry.
Yeah. It's 7:32. Thank you for a spirited discussion, and thank you to our audience for actively participating in this session. We'll be back next time with Dr. Hannah Wunsch. She will be our speaker on February 10th. So till such time, have a great day, everybody. Thanks, Dr. Brock-Utne, for an awesome presentation.
Oh, thank you. Thank you much. Have a good day. Bye-bye.
Bye.